today. This is the patient data matching survey results. We're going to be talking about, are we close to a solution here, and looking at patient matching in light of COVID and how that has really changed things. And we've got some really interesting results to share with you today. So we're going to go through those. Again, I'm Jen Kovich-Bordnick, CEO of eHealth Initiative. And as I mentioned, I have three delightful, incredibly intelligent folks who are going to bring their insights to us today. I've got Mark Leroux, the CEO of Breakdow, Ed Hammond with the Duke Center for Health Informatics, and David Cates with Manifest MedX. Three, I think, really spectacular folks, and you're really going to enjoy hearing from them, their insights on the survey today. And then we're going to close with some Q&A. We've got a pretty good discussion lined up for you, but we are anxious to hear your questions as well. So please feel free to submit those through the Q&A box for us to get to at the end. We'll save some time. Real quickly, for those of you who are not familiar with the eHealth Initiative, we are a nonprofit in Washington, D.C., celebrating our 20-year anniversary. We do education, advocacy, and thought leadership, all focused on how do you use healthcare innovation to improve care. We do all sorts of activities and roundtables, educational events. You're most likely on our mailing list if you're here today, and we invite you to join us. We focus on 4 critical issue areas right now: privacy, virtual care, analytics, and of course, COVID-19, best practices in the area of healthcare technology around COVID-19. A lot of our webinars this year have been focused on that area. This is just a sampling of some of the organizations and executives who are involved with us. We primarily convene executives to really discuss these 4 critical issue areas, try to identify what's working, and share in an executive forum with other folks so that we can really help spread the word around the country and support these innovative measures. If you don't see your organization's name up here, it should be up here. So please reach out and contact myself or Amy Eckenroth. You're welcome to reach out through the chat box, and we'll follow up with you after the session today. But we want to get as many different stakeholders involved in our process. We're really about including everybody across the spectrum of healthcare. This is a sampling of some of the forums and webinars we've held just this year in the last 6 months. These are all available free of charge on our resource center at ehighDC.org. I encourage you to go check out some of these materials and resources. Again, we want to promote what works and share with you best practices from around the country. So I encourage you to look these up. Coming up, we've got some really great activities happening today. Of course, we have this spectacular webinar. If your colleagues aren't able to join today, this will be posted on the website later this afternoon or tomorrow, the recording, as well as the results from the survey, the PowerPoint. So you're welcome to share that as well. We do also have a webinar next week looking at virtual care on December 16th. Which should be really interesting. We've got great perspectives from different innovation centers and hospitals around the country that are using virtual care in light of COVID right now. January 12th, we have a great program lined up looking at diversity in clinical trials around COVID and how this is impacting both the development of vaccines and also vaccine disbursement. And we're going to have a number of different pharma executives available with us at that point to talk about it. So it should be a great program. And we have our eHigh annual member meeting coming up the 26th to the 28th, and that will be virtual. So I encourage you to join us as well. Check out a list of full events there at eHighDC.org/events. Our publications are also available. Again, just a sampling for you to go ahead and please check out some of this important work that's happening right now. And finally, last but not least, I want to thank Mark Leroux and Breakdow for their support of this. As I mentioned, we're a very small nonprofit, and we would not be able to do the research and the hard work involved in this if we didn't have the support of innovative organizations that are out there on the front lines, like Breakdow, who's doing a lot of really critical work in patient matching. It's great to have somebody who's a patient matching expert to talk about the results of the survey today. So welcome, Mark, and we're delighted that you're with us. And Mark's going to share some personal perspectives and comments after we go through the results here and lead the discussion for us today. But I do want to thank Breakdow for their help and support of this. Housekeeping, again, if you have any questions, feel free to raise your hand, type in a question there, and we will get to it. We're going to save a little bit of time at the end there to get to your questions, so please do that. If you've got technical difficulties, feel free to enter them in the chat box there, and we've got Sarah who will help you. Okay, well, let's just jump into the survey results. This survey took place between October 17th through November 7th. We had a little over 100 respondents. About 40% of them were executive level management. And I just want to be clear that most of the analysis that we're going to talk about today, you can see the chart here presented will show you the arrangement and the variation in terms of the types of respondents to the survey. For the purposes of the discussion today, we're primarily going to talk about analysis that does not include the vendors here. So you can see about 15% of the respondents to the initial survey were vendors, and we didn't want to include them in some of the analysis that we're doing today. The analysis that we're going to talk about today, we're going to drill down on a number of different areas, includes this group of survey respondents, about 20% hospitals, 27% HIEs, 13% payers, public health, practices, nonprofits, mental health, and pharma. So just want to make that clear who the respondents are that we're talking about today. These respondents came from different areas in their organizations. About 35% were top tier executives, about 20% were analytics, 16% management staff from IT, and then assorted others, as you can see here. Again, these are all non-vendors. And just to give you an idea, we asked these organizations how many of them, their current organizations were doing using patient matching, and about 66% knew that their organizations definitely were. About 23% said no, and about 11% were not quite sure. Now, if you take this a little bit farther in terms of the current use of patient matching breakdown, so if you look at just the hospital systems that responded to the survey, just the HIEs, and just the public health organization. So 100% of the hospitals that responded to this survey were in fact using patient matching. About 80% of the HIEs that responded to the survey were using patient matching systems. In the public health area, only about half of the organizations that responded were using patient matching in their organization. And this is a trend we're going to see as we go through here, that public health is not necessarily in the most sophisticated category as we get through here. We did ask organizations how confident they were that their systems were actually matching patients to their correct health information. So this is what patient matching is all about. Can you connect the right person to the right information? Does it actually belong to them? And what we found was about 55% said that they felt pretty confident that the information was matched to the right health information. 36% said it was somewhat confident, and about 10% were really not confident at all that the information, patients were matched correctly to their health information. Again, if we break this down and look at some of the key stakeholder groups that are collecting and using patient matching systems, you can see here hospital systems, 50% were somewhat confident that they were accurately matching health information. About 40% were significantly confident in it. HIEs seemed much more confident that they were matching the information to the correct health info, about 79%. And public health, really not a good indicator here. Only about 50% felt that it was even somewhat accurate, and half of them thought that it wasn't at all. So that they're not necessarily matching the right information to people. We also looked here at, specifically, are you matching it to the medical record? And 64% overall of this group felt that they were confident that it was at least getting matched to the right medical record. Again, if you look at the breakdown here, you can see 63% hospitals said that they thought that they were, 74% thought that the HIEs, that they were definitely matching to the right medical record. And in public health, they were a little bit more confident that they were able to match to the right medical record. So that's 83% here. Areas that are impacted by patient matching challenges. So we know that there are a lot of challenges to these systems and matching information up. We know there are all sorts of issues with duplicates, wrong names, mismatches, inaccurate data, bad data in, bad data out. And this is what it's really impacting in terms of organizational areas. Operationally, 24%, IT, about 15% is impacted, analytics, 18%, patient experience, 12%. But hey, look at this answer here. 62% of respondents felt that all of these areas are actually impacted. And that this is, I mean, a tremendous challenge here. So this is really, I think, shows you how difficult this is. And that was pretty much clear across the board. We asked, what's the impact of incorrect patient data matching? What happens to the patient? And what we see is, again, poor treatment decisions, poor quality of care. It impacts your reputation. It impacts your revenue. Poor patient safety, all of these things are directly negatively impacted when you don't have the data and you don't have the right patient that you're looking for. And I think, clearly people are very much aware of why this is necessary. So there have been a lot of discussions, and I think the panel will get to this discussion as well, about, do we need a national patient identifier? And I know that that's been up for debate now with a lot of the systems and algorithms we're able to use, that we might not necessarily need a single patient identifier any longer, because we've got some pretty sophisticated algorithms that allow us to identify people pretty accurately. But there's still a lot of talk about, what's the likelihood of Congress actually enact some sort of national patient identifier legislation. And we asked, within the short term, within 5 years, so during the next administration here. Not a lot of confidence here that this is going to happen. About half, 46%, not at all confident that this would happen within the next 5 years, which really leads us to think that, most organizations are probably looking for a private sector solution and not looking for policymakers to come in and solve this for them. Another area we talked about was looking at what's the need for greater interoperability between providers and the public health during the pandemic. And we know that the pandemic has really shown a light on what's kind of wrong with interoperability. And about 85% felt that, this has really shown, there's a need for greater interoperability because of the COVID-19 pandemic. I don't think this is surprising to probably anybody on the call today. Clearly, we need systems that talk to each other and can help us deal with this pandemic in terms of testing, tracing, vaccine disbursement, all sorts of treatment and care. So certainly that's important to all of us. The importance in terms of having good patient matching to identify at-risk COVID-19 patients. And we know this is happening around the country. I'm in the state of Maryland, and I know Maryland and CRISP and a number of organizations have a task force going to actually use patient data and go in and identify at-risk COVID-19 patients. About 71% of respondents said that they know that this is significant and important to identify these at-risk COVID-19 patients. So I think pretty much clearly across the board, people recognize this, 24% somewhat, and only 5% not at all. So how efficient are we at identifying patients that are actually at risk of COVID-19? How well do we do this now? Only about a third said that we are significantly or very significantly efficient at this. About a third said we are somewhat efficient, and about a third, 30%, said not at all. So I think this is, pretty much probably depends on what part of the country you're in and what institution you're at right now, whether or not you're able to do this efficiently and actually use that patient data to identify somebody who's at risk of COVID. And we believe that, patient matching and all the challenges around patient matching have become much more apparent during the pandemic. So we asked, respondents, have you seen that as well? And about 41% of respondents said that yes, they had seen that this has become much more apparent during the pandemic. About 31% said it's only somewhat more apparent, and about a third, 28%, a little less than a third, a little more than a quarter, it hasn't been more apparent during the pandemic. And again, I would imagine that's going to matter what part of the country you're in or what type of stakeholder your group you're in. If you look at this breakdown here for this question, you can see that during the pandemic, for public health, it became very apparent, 75%, that patient data matching is a challenge. And I would say a struggle for public health organizations. HIE, only about 42%. Hospital systems, only about 30% felt that it was very significant or significant. So you can see here again, public health is really struggling with identifying and connecting people with the right data, and probably don't have those systems in place right now to do that. So these challenges around patient data are much more apparent, and COVID is just really making it more obvious to us, I think, as we move through here and deal with this crisis. So we drilled down a little bit and asked about data patient matching and how important is this to contact tracing? And 83% overall felt that it's really critical to be able to match the right patient to the right information in terms of contact tracing. And this says contract tracing. So we've got a typo in here, which I apologize for, but that is contact tracing. The confidence in individuals being able to accurately be identified for contact tracing, only 27% felt that they were very significantly confident or very significantly confident that they were accurately identifying individuals for contact tracing. And then, of course, the ever important vaccine distribution, which is top of mind for most of us right now, I think. Very delighted that, we've got these vaccines that are going to be available shortly. But now I think we're all thinking about distribution and being able to track who needs a vaccine, who's gotten a vaccine, who's gotten their first shot and their second shot. And, clearly out in the healthcare field as well, 75% believe that this is going to be really important, that you can track these patients and their data correctly and accurately to do vaccine distribution. 75% feeling that this is really significant or very significant to vaccine distribution. Again, looking at the breakdown here, by stakeholder group. Again, I think pretty much everybody across the board, hospitals, HIEs, and public health, the three groups are probably most engaged in this vaccine distribution process at the moment, also felt this was very significantly important to distribution plans. The importance of patient data matching to tracking testing. So this is what a lot of us are dealing with around the country right now. Have you gotten a test? Can you get your test back quickly? Can you share the results of your test? Can we track who's been tested? 80% overall felt that this was very important. Patient, being able to match the appropriate patient to the appropriate information is significantly or very significantly important to tracking in testing. And this, okay, so who is ultimately responsible for matching patients with their data during a pandemic? And, is there a right answer to this? I don't know, but we thought it would be interesting to ask people's perspectives here. Who do you think is responsible for patient matching, during a pandemic? Who's responsible for matching the public and knowing who's infected, vaccinated, tested, tracking all of this really population health data for the general public? 78% of respondents felt that it was public health agencies that should be responsible for this or are responsible for it. 68% felt that it was providers that should be responsible for the patient data matching of the public during the pandemic. So I think that that's interesting as well. And 50% felt that it should be labs, which should be tracking this. So I think some interesting responses there, Mark, and we'll see what the panel thinks about that. again, I know there's a lot of discussion about who should be paying for this, who should be tracking all of this during the pandemic. And this just sheds a little bit of light in terms of what people are thinking in the healthcare field. And the single green dot, I just wanted to share this with you. You know, correct patient data matching can improve the patient experience. 100% of survey respondents agreed with this. It's very rare that we get 100% of survey respondents agreeing with anything. So I did want to share this, that I think we all recognize clearly, and respondents do as well, that patient data matching, if you've done it correctly, can really improve the patient experience. Which I think clearly by the survey results, we know that not doing it correctly can clearly detract from the patient experience. And that's what I think we're seeing in the rest of the survey results here. So just some initial conclusions, and I'm going to pass it over to Mark here in terms of the data. I think, you know, we can see from the data that the pandemic has really highlighted the critical needs of patient matching for tracing, testing, vaccines. All of these different groups recognize the importance of this and that it needs to be done. The challenges, you know, HIEs, hospitals, public health all recognize that patient matching challenges are numerous, but I think this is particularly stark when we look at public health groups here who don't seem to have these systems in place and seem to need them the most. And the public clearly believes that they are the responsible party for this. And they have the systems that are not in place. So I think that this is a really interesting point here, certainly a policy question. And an ethics question, really. And then public health and providers are perceived as a responsible party for patient matching. Now, I know that, you know, public health certainly, but I think it was also interesting that providers, hospital systems are seen as responsible for matching this patient data. And I don't know if that's because people generally see those groups as leaders in the industry, but that would be interesting to discuss as well. And then finally, you know, there are really minimal expectations here in the short term from Congress in terms of passing any legislation around a unique patient identifier or patient matching here. So that was interesting as well. I think if we had conducted this survey a few years back, there probably would have been a higher expectation that Congress would do something. But we're certainly at the point right now where people are not expecting much from Congress. And with that, I'm going to turn it over to Mark LaRoe for some great comments here. Again, Mark LaRoe, the CEO of Verado. We're going to take a deep dive here. And Mark, I'll let you introduce Ed and David here. And I know you've got some initial comments here as well. So welcome, Mark.
Thank you. Thanks for hosting this. Yeah, hi, everybody. I'm Mark LaRoe. I'm going to have each of our two panelists appear on the screen and introduce themselves in just a moment. But let me do my, and I've repeated a couple of your slides, Jen, in this latter half here so we can speak to it directly since there's so much content in your material there. But in any event, everybody, hi, I'm Mark LaRoe. I'm the CEO of Verado. And go ahead and go back one slide, Sarah. I'm not ready for this yet. I'm the CEO of Verado. And for those of you who don't know who Verado is, we're a SaaS software vendor in the patient matching space. So we sell software that matches people's identities across databases within an enterprise, across enterprises, and across industries even. So we've been in this business for quite a while, at least in terms of technology. We've been doing it now for 6 years. But what we're known for is we're the inventor and the pioneer for this new form of matching called referential matching. With that said, we've got over 50 large customers, many HIEs, many of the more innovative hospital systems. And I'm very happy to say, based on the survey results we saw, that we've now also been deployed at 2 public departments of public health. So that 50% or 60% lack of identity matching capability within our public health sphere, they're starting to chip away at that problem. Well, that's me. Ed, can I ask you to come on screen, and Dave Cates also, start your video. Ed, will you give a short, give your introduction, please?
Okay, my name is Ed Hammond from Duke University. I've been involved in informatics before there was something called informatics. created one of the first electronic health records starting in 1969. I've been very much involved in standards, working with HL7 and now FHIR. I've been a proponent of solving the problem of patient matching since 1990, when we thought we had a smooth pathway to getting a universal identifier, but ran afoul of ACLU and the press at that time because of privacy. I'm delighted to see this topic coming back up again, and I'm looking forward to the remarks that we will make. Thank you for letting me be.
Thanks, Ed. Dave?
Hey, everyone. Dave Cates. I'm the Chief Technology Officer at Manifest MedX, which is the largest not-for-profit statewide health information exchange in the state of California. We've got 25 million unique lives, and we're pretty sure they're unique based on our patient matching technologies. Out of the 39 million lives in the state of California. I've been involved with health informatics and health information technology throughout my career as well, at times crossing paths with Ed and Mark. Ed and I served on the first board of directors of HL7 back in the 1980s, and I'd been involved prior to that with that organization, and have been involved with patient matching both as a product owner at Cerner, where we were involved in implementing some of the early clinical information systems / EHRs, and a couple of HIEs, a startup where we tried to build our own patient matching technology to share radiology images in the 2000s, and currently ourselves and our peer health information exchange organizations using commercial technologies to do patient matching, which is sort of a cornerstone of HIEs across the country. So thanks for inviting me to this session.
We're happy to have you, Dave. And in fact, if you haven't figured it out, I invited Dave to represent this problem from the HIE's perspective. They play such a critical role. And I invited Ed to represent the perspective of hospital systems, providers, and people who've just been immersed in the care of patients, to represent that perspective. And before I even show any supplementary slides, maybe I'll just kick this off by asking Ed or Dave if they've got any top of mind thoughts on any of the data that Jen's just presented. Does anything stand out to you, either of you, as top commentary?
Dave, go ahead, and I'll follow you, David.
All right. So it was illuminating, but not surprising, that public health is sort of the poor stepchild in some of the responses to the patient matching thing. I think there's a huge need and a huge expectation. I know in a lot of, I think across the country, but I can vouch for in California, public health is organized by the counties. And so the state has a statewide registry. The lab information that is sent to the state and then disseminated to the counties, nobody has traditionally focused on patient matching. And as a result, number one, they can't figure out unique lives that are testing positive or getting tests. Two, some of the things they'd like to be able to understand about the patients, you know, in the current crisis and in general, like racial disparities and things, there's a huge interest in that, but there's an inability to do that. And frankly, the data sources that provide it. So it's partly a technology issue for them, but it's partly a workflow and data availability issue. So it doesn't surprise me. And, you know, it's a blessing in disguise that this is now creating a focus around the need for patient matching in public health in order to meet those needs that I think we'll talk about some more. But Ed, you had some thoughts as well?
Yeah, thank you very much. I must confess that I filled out this survey and I didn't use a lot of brain power in doing so. I gave fairly obvious answers. But now, because I've got asked to be part of this panel, I looked at it differently. And, you know, one of the things, my first problem is a simple problem. What do you mean by patient matching? Are you trying to find a single patient from the electronic health record, or are you trying to take the fact that that patient may have two records and putting them together again? And when I started thinking at it from that perspective, looking, for example, at providers, at the doctors taking care of patients. They're pulling in a record. If they get the record of the patient that they are interested in, it's not important to them whether, well, I take that, not saying it that. They aren't worried about finding another record or another record about this patient. They deal with what's in that particular record. And so it shifts. And if you talk about public health, which looks not the greatest in the survey, but you've got to remember what data do they have to guarantee that they have truthfully the right patient, the patient they're matching, because they can't go back and can't compare. And so I think the whole perspective is very different depending on what you're doing, how are you using the record, and what additional data. And maybe the people that are involved in IT have, and the analysts perhaps, have greater motivation for looking to see whether there are duplication of records than the people that are taking care of the patient, although it's extremely important from the perspective of patient safety. A number of reasons why it's important, but they don't spend their time trying to find out if there are multiple records. So that totally changed my perspective on analyzing the results.
Yeah. And you're also remarking to me, Ed, just before this started, that you were surprised to see so many senior executives responding to this survey about something as arcane as patient matching.
And we both agreed that probably 10 years ago, they would have no idea what those words meant or could care what those words meant. So that's a good reflection of change.
Yeah, it is. Go ahead, Dave.
Oh, no, and I'm sure we'll get into some more of the discussion, but there's a different lens on it too, Ed, in terms of sort of the absence of patient matching, partly what Jen spoke to on patient satisfaction, like, well, two examples. In the HIE world, in addition to wanting to present a consolidated patient record and not commingling data from two different patients, which is, you know, just really harmful. One is most HIEs either have some sort of opt-in or opt-out privacy policy. And so if you don't get the right patient and honor their desire as it relates to opting in or opting out, and you don't match a record and it becomes exposed to members of the community that they didn't intend for it to get exposed, that has a huge dissatisfier and causes a whole lot of feathers to fly. And then our other constituent, other stakeholder, like Jen said, it depends, you know, where you stand, depends on where you sit. We have health plan participants who we constrain to have access to data for just their members, even though we see the entire community. And there have been instances where patient matching wasn't done correctly, and we weren't able to notify the health plan that a member of theirs just arrived in a hospital or was just discharged. And they have both regulatory obligations and authorization responsibilities, and they don't have visibility to that. And they find out through out-of-band mechanisms that one of their members presented, and that causes them operational and financial issues as well. So there's all sorts of different lenses on this.
Yeah.
But let me ask another question of you all, because how do you know that you are perfect in patient matching? Because the biggest violation of privacy is, as you've indicated, but it's the fact that somebody else's data goes in my record. And there are times when I recognize that who the person is whose data is in my record for some particular reason. And most people that tell me they have they're 100% perfect in doing patient matching only mean that the data elements that they are using for patient matching, they think that they have 100% of those data elements collected. But most frequently, you're missing some of the data elements, and the algorithms compensate for that, but it's opening. I just noticed that whenever I took my video away, you saw William Hammond. I got introduced as Ed Hammond by one, and your slide said W. Ed Hammond. And so trying to match my name, and you can say, well, we'll do your last name. But then what do you do with the people that have a professional last name, the women particularly, have a professional last name and a married last name? I mean, you know, it's demographic data is extremely difficult to keep it absolutely stable.
Well, let me take an opportunity to kind of build on what you just said, Ed William Hammond. William Ed Hammond.
William Ed.
William Ed.
Sorry. and then just give my perspective on the overview, and then we'll dive into a couple of smaller details. But look, it's exactly as Ed says. The problem of patient matching is very parochial. Within a hospital system, hospital systems have been dealing with this for a long time. There have been a lot of workarounds. Physicians know not to trust that they've got all the data. They know to adapt, and we kind of learned to do that. And frankly, if nothing else it was changing, we'd probably still be okay at that status quo within the four walls of a hospital or the perimeter of a hospital system, except for the fact, and this is what Verado customers are seeing, except for the fact that there are many more systems, even within a hospital, that are starting to exchange data about patient. There's not just the EHR, but there's the telemedicine system. There's the CRM system. There's the digital front door, and there are the analytics, the four big ones that we call. And these are all sorts of new systems coming into play for which Epic is not the proper integration point, or Cerner's not. Not to say anything really bad about EHR, they're just not flexible enough. And that's the problem within the four walls of a hospital. Now look at Dave's problem. Dave is worrying about combining data across hospital systems and other close affiliates, payers in the case of Manifest. That's much harder because far less control about the data inputs and the data usage. But even that problem is now becoming somewhat known, and organizations like Manifest and the other big successful HIEs have figured out how to do it to some level of efficacy. But now we've layered on this problem of a pandemic where it's not just hospitals and close affiliates of hospital systems. Now it's public health, labs, soon it'll be pharmacies as we're distributing vaccines. So the ecosystem by which we're exchanging patient data is getting geometrically more difficult. And a truism about data is that the more sources of data, of the same data that you add to a system, the greater the chance of an error. And that, I think, is at a highest level the problem we're all facing. It's the interchange of data that's highlighting all the issues.
So let me make one more comment. Mark, I know you're trying to control us to get to some of your other questions, but one of the things that at Duke, we're required to get a flu shot. And there are multiple places we can go to get a flu shot. But one of the things that I absolutely guarantee that I do is to make sure that wherever I get my flu shot, whether it's CVS or whether it's a couple of places at Duke, it ultimately gets back to my patient record. And it isn't guaranteed. Almost every year I've had a major fight. But my motivation is to keep from getting the second flu shot or for getting in trouble at Duke. Yeah. And so when you're talking about who is responsible, I'm beginning to believe more and more the individual patient is responsible for guaranteeing that the data that's contained within the health record, particularly now that we have health portals and they can look at that data, I think that's going to be the best way in the future of knowing how good we are at putting all the data within the record. So I think it's the responsibility is going to move to the individual, and I don't think there's anything wrong with that.
Ed, that's such a good point, and I will move to my slides, but I'll just put an exclamation point on that point you made, because I intended to do it too, and you beat me to it, which angers me, but because I hate being beaten by you. But no, it is the patients have unbelievable visibility now into their medical records through the portals, through the digital front door, through everything through the health apps that are going to be distributed to everybody. And this is an uncomfortable conclusion for so many hospital systems. Any errors you have in either the aggregation of data or the overlap of, the overlap data or the ability to not find data is going to be front and center in front of your patients. And they're the ones who are going to be judging you, the hospital system, not based upon your care, not based upon the doctors and their degrees, but on how they feel about their interaction. And right in the front of that interaction is, do you have my data in order? Okay.
Yeah, and I would just partly be controversial, but partly based on reality, like the group of us and the group of hundreds of people that are assembled on this call, we're pretty highly motivated and highly aware. But if you look at, and now we're getting a pretty far off, but we'll pull it back in. Like if you look at PHR adoption and you look at, Fire and Apple and other major vendors that are taking advantage of the open sharing of information with consumers. And I spent some time at WebMD, like the engaged consumer is still the minority. in a big way. I think it's shifting, and I agree there's,
Yeah.
you know, the people that would be most vocal if they didn't have your flu shot on record are motivated. So you want to take advantage of that. But at the same time, because of the, you know, the reimbursement system and the way healthcare is structured, you know, the health plan or the provider organization may be at risk for the cost, but the unengaged consumer that hasn't taken the trouble to go make sure that the medications that they take at CVS don't, you know, are on their record, that you have to solve that problem too. So I think it's both. I think there's sort of a matriarchal responsibility that the systems be in place to help put the pieces together, but also the consumer, where you can get them motivated, could also play a role in that.
Yeah. Let's put up the first slide. Dave, I'll just, I think maybe it's a generational issue. True story. My son came to me yesterday and said, "Hey Dad, my son who's living in the basement, quarantined down there, came to me and said, 'Hey Dad, you know, they've got these patient portals now and you can see everything that they've done for you.'" And I go, "Yeah, Stephen, I knew that because I'm in this industry, but it is a generational thing to use these tools." Look, just one slide that I wanted to put up, and then after that, we'll get to some of the slides that'll tee off a couple more questions. And I know we're running short of time, and I do want to take the questions that are coming in. Look, this issue of patient matching has been around for a long time. Ed's been involved in it for quite a long time, and I trace the roots of it all the way back to an IBM research paper back in '69, believe it or not, where the basic idea of probabilistic or algorithmic matching came into play. And this fundamental idea with its birth in 1969 has now manifested itself in all sorts of software, EMPIs, EHRs, HIE software. It became the state of the art, but quite frankly, it's been the same basic algorithm with refinements for healthcare, for different, but it's the same basic algorithm for now, what is it, 60 years. But, and I think everybody would agree over the last 10 years, there's been very little innovation. And that's kind of the genesis of the chart you see on the right, which wasn't part of the survey. This comes from other widely industry quoted surveys about duplicate rates. The average duplicate rate in hospital systems was 12% in 2008. It had risen to a height of 18% in 2018. And the question is, how bad is it going to get? It's getting worse, not better. And I'd suggest it's not getting worse because the technology is getting worse. It's getting worse just because we're asking more of it, with all of the interconnections and all of the data we're feeding into it. So the conclusion here that I put out to everybody is that we have to think about doing something different. We can't stay with the same technology if we're going to start solving the problem. Go ahead and go to the next slide. Yeah, these are some repeats from Jen's slides earlier, and I just wanted to put an exclamation point on this issue of public health. It says 50% said no, 13% said not sure. Not sure probably means they don't have it. So it's really like 2/3 of all public health isn't using patient matching technology, which means they're doing it manually in spreadsheets, which means it's absorbing all of the people's time to get it partially right. And that is a real problem for the country. Go to the next slide, please. Yeah, now this, I wanted to put this slide up again. This is about the confidence in patient matching as perceived by hospital systems, HIEs, and public health. We won't speak anymore to the public health confidence, but Dave, maybe just a few words on the level of confidence HIEs can have in their matching and what you have, or even just the challenges an HIE managing 38 million lives?
25 million of the total population of 39 million, yeah. So I think this number is super high, partly because it's foundational to HIEs. So we spend a lot of time and effort and money, both with the technologies that exist, the probabilistic, deterministic, reference data types of tools that exist in the marketplace. So we feel it's high, but it sort of ties back to Ed's comments and just what we've talked to you in general. We're also laser focused on it enough to know there is no such thing as 100%, because the technology could be phenomenal, but the robustness of the data that we get and the reliance on the data entry people at the front end that capture the information, and some of the just edge cases of newborns and trauma patients and gender changes and people moving around, like it's just a complex problem. And so anybody that says they've got it nailed is wrong. And so at the same time, we are confident because we spend a lot of time and effort on it. It can't be perfect. And so both the systems and quality control and processes and litmus tests and, you know, the things that you need to do on an ongoing basis to go up the food chain to perfect it, and or you know, a national patient identifier, which still would have operational challenges to it, but like there's fundamental changes that to make it move higher up the scale.
Yeah, we'll talk about that in a minute. So hold that thought.
Okay.
Ed, any perspectives from a hospital system, either historical or present day? What do the hospitals think about?
Well, obviously, one of the points that I would make is Duke now has expanded hospitals. There are now 3 hospitals in the chain. But most importantly, a couple of years ago, we brought in a clinic that has several thousand patients in it and moved those records into the Duke EHR system. And many of those patients had encounters already at Duke. And so we had a fairly major problem of bringing in one group of patients into a system that already contained their records. And we've had a very difficult time of separating those. My comment that I would make is an easy way to find out whether you are perfect or not is simply find out how many of your patients have had an encounter after a date of death.
That's an embarrassing statistic too. Nobody's going to publish that. All right, let's go to the next slides. So the problem is different, but pervasive. This slide I just put up again, not to dissect the data itself, but to see, Dave, either whether you or Ed had any specific comments about how things might have changed from your perspective because of the dynamics of a pandemic and the interchange that's happening now. Anything specific from an HIE perspective, Dave?
The one specific thing that's come up is the counties in the state that rely on our data have more demand for it. So it's become a heightened area of attention to be able to uniquely identify the patient and supplement data, because those consumers, those stakeholders not only need to uniquely identify the person and associate their test results, but contact tracing and identifying occupation and things that might inform them in terms of how to follow up have become that much more important, as well as being able to go and let caregivers in those communities be aware when the county public health does the testing to make them aware that somebody's tested COVID positive. So it's really just put a spotlight on it.
Yeah.
And what I would add to that is the fact that we don't know enough about COVID yet. And so it really requires research, and research requires big data. And you really can't do the research on a single institution. You really got to bring as many institutions as you can, bring that data together. And we don't know how many patients have multiple encounters at multiple institutions. So there is a record of duplication in that. And then the other part of that is there are other kinds of data and imaging data. It turns out the imaging database as part of the N3C project is separate from the clinical database, and trying to match those patients, again, is a challenge in patient matching. So there are lots of motivation as we try to learn more about these diseases that require the aggregation of data across multiple settings.
Yeah. Multiple settings is the issue. Let's go to the very last slide, because I do want to leave time for Q&A, but I did want to also ask everybody their opinion, personal or institutional, about the efficacy or the timeliness of a national patient identifier. And maybe I'll start off this so that I can read some of the questions while my 2 panelists are also giving their point of view. My point of view, for what it's worth, is I'm very much in favor of national patient identifier with small letters, not capital national patient identifier, but rather a number, almost any number, social security number, phone number, driver's license number, any number that is unique that can be used to help in matching. And the one caution I will give is that I think everybody should be on guard for the entire country or the health system to become reliant upon a number, because ultimately it's a fundamental break. If any errors in a number means a 100% error in matching. A small error in a first name doesn't completely cause a mismatch. So I think a national patient identifier has a big role to play, just as Social Security number used to have a big role to play, albeit never perfect, but a great aid. Ed, do you want to go?
Well, I'm in favor of a national identifier. I appreciate your position on it. In fact, what I would say is most of the large systems that have multiple sites as part of that system create their own number. And again, the reason I'm in favor of a national identifier is the fact that, one, you can build in check digits into that identifier itself and find out whether some of those numbers have shifted or not. But you can use it for other things. You can use it like an area code to show you the location of an individual's record. So what I'm really suggesting is we don't focus on just the identification of an individual. There are other things that relate to that. Census being one of those, that I can use that with a minimum data set associated with that to do the census automatically. So I think what I want to do is to have somebody look at the bigger issues, all the different kind of things that I can do with that single database about a patient, and they're distributed across the country. It's not one big database in Washington, D.C. It's scattered throughout the country. It's associated with where the patient record is, which we've never mentioned, but there are times when I need to know where a patient's record is, even from California back to North Carolina. We actually have had an example of a person from North Carolina there. So long story short, I think things have changed. Privacy is no longer a factor that should suggest we don't do this. And the bottom line is, I've never understood why we're fighting over a way to get to the same vault. The vault is the data itself, and we've got two keys. One is more perfect than the other.
So my comments are fairly short and pretty consistent with Ed's and Mark's. I think it would, the obstacles in the past, I mean, the political obstacles remain, and the political environment being what it is, but it would certainly improve on a situation that's critical, as we've talked about for the last 45 minutes. And we should learn from the types of challenges that we've had to solve in dealing with less perfect data, because those won't go away entirely. The trauma patients, the newborns, like dealing with people that, whether, you know, and you can put check digits in and avoid transposed digits and things like that, but there are still edge cases at a minimum, but we reduce those number of edge cases and it makes sense, but that's not to diminish the political challenges of people's perspectives, or I might disagree with that in terms of like the privacy. I agree from an engineering standpoint that the privacy issue's gone away, but from a public opinion standpoint, I'm not sure that people perceive it that way.
But I can guarantee privacy.
Right.
If I know who you are. I mean, that's the point Mark made. I mean, so I'm not saying no privacy. I'm saying I can do a better job of protecting your privacy if I know who you are.
Yeah, that's it. Look, let me. I opened up the questions. There's a good number. There's 14 of them. Each one's a paragraph long, so I was only able to scan the first few. But I'm going to answer. I'm going to mention one of them, and if you guys want to look and see another question, you might want to answer. But what do we do about the general inadequacy of patient-level race and ethnicity data, which is important for patient matching, although I'm not sure it's important for patient matching, and is helpful to address health disparities of populations that have become particularly apparent during the pandemic? And I actually have a quick answer to this one. So look, the public health institutions that Verado is now just working with have asked us specifically not just to match patient data, but also to bring in external data, more demographic, psychographic, ethnicity, race, job, income, things like that, so that real analysis can be done on entire populations. And so, so it's not just a matching problem, but it's a matching and a data augmentation problem. But the good news is, if you've got a good matching engine, all that other data is available to be matched. And it is starting to be done. But public health hasn't paid attention to it in the past because they haven't had to. I don't know if anybody's got another.
Well, the only thing I'd add is race is the most difficult data element to collect, because how do you determine it? Is it because the receptionist is looking? Do you ask the person? There are a number of those kind of issues. I hope that one of the outcomes of this is we do full genomic sequencing of all the population. That doesn't solve some of the issues, but solves some of the health-related issues to the race. We do the best we can. Many of the projects that I've been engaged with, they only do part of the race. And that's when you're doing research and you've only have black and white, for example, you really don't know what the impact is on the Hispanics, and missing that, you can't assume that they're not there. So it's extremely important.
Yeah. Look, we're running a little bit out of time. There's two questions here that are very closely related, and maybe Ed, you can respond to this. Can you speak to how far technology can go to doing matching, and how much must remain as human intervention? And the other person said, I'd like to ask the speakers if they have one or two or more FTEs devoted to data integrity and stewarding the data.
Yeah, Duke has a full analytics division, and part of that is quality control. We have a chief quality officer that looks at those issues. So the answer is we pay a great deal of attention to the integrity of the data. We're getting better, but we're still a long way from perfect. And until we apply technology appropriately, then we'll never get to acceptable levels, in my opinion.
Yeah. The Verado answer to that question is, and this is a recognition to something Ed said, is our technology is not perfect either. I mean, it can't be. We not only can it not be provably perfect, because you can't get to ground truth on a huge population, but no technology is perfect at identifying people given the high variety of data. What we do offer our customers, though, is we say, whatever you were doing, whatever FTEs you had stewarding data in the past using conventional technology, you'll need 1/4 of that going forward with Verado, because we have far fewer undetermined matches, we call them.
Yeah, and we're experiencing that with the technologies, including Verado and others that we've used. And I think it's shifting too. We definitely have some dedicated FTEs on data quality, specifically around patient matching. But it's this sort of technology societal shift from looking at the data itself to more the man-machine interaction, and looking at the analytics and the tools, and looking at patterns, and potentially looking at outliers. So using the machine learning and the AI technologies that are embedded in the patient matching technologies exist to do spotlighting and figure out where there might be issues, rather than focusing people on like looking at names and spreadsheets.
Yeah, that's right. Fix it in an aggregate fashion. Well, look, everybody, we're at the top of the hour, and I appreciate everybody's attention. There's still the vast majority of participants are still online. Thank you, Jen, for hosting this. Thank you, Ed, for being a panelist, and thank you, Dave, for being a panelist.
And thank you, Verado, for sponsoring today.
You're welcome.
You guys were fantastic. Thanks, everybody. And if you're interested in a copy of the results or this wonderful discussion, it'll be available online later today.
Okay.
Have a great day, everybody. Thank you.
Bye-bye.